Hi everyone, my name's Lucas and I'm going to talk to you today about seeing a patient with testicular pain. So just the objectives for today, we're just going to quickly understand the anatomy of the testes and spermatic cord, and then following that we're going to understand how to approach an assessment and management of a patient with acute testicular pain. So some brief sort of overview of the anatomy as always. So we've got the skin and the dartos muscle here as the sort of outer layer of the scrotum. Followed by this, we have the sort of cord neurovascular structures and the testis itself. So from out to in, we've got the external spermatic fascia, followed by the cremasteric muscle and fascia in between, and then further deep to that, we've got the internal spermatic fascia, and that's sort of the layers of the cord and the surrounding layer of the testis as well. Deeper to that, we have the testis. So we have the tunica vaginalis, which is the layer that invaginates the testis, which is how I remember it. And then deep to that is the actual fibrous layer of the testis itself, so the tunica albuginea. And albuginea means white coat in Latin, I think. So that's just how I remember. The outer layer is the vaginalis, inner layer, and the fibrous layer of the testis is the albuginea. There's also the sort of structures of the within the spermatic cord. So there's three arteries, so the testicular, the artery to vas deferens, or the deferential artery, and the cremasteric artery. We've got three nerves, so the genital branch of the genitofemoral nerve, cremasteric nerve, and the sympathetic nerve fibers. And then three fascial layers, so the external spermatic fascia, cremasteric muscle and fascia, internal spermatic fascia, as we discussed. And then three other things is the vas deferens, the pampiniform plexus of veins, and the lymphatic vessels. So the way to remember all the structures in the cord, going to the testis, 3, 3, 3, and 3. So just take some time to learn those, especially for exams and things. Fine, and the patient case. So we've got a 21-year-old male. He's referred to by A&E with sudden onset of right testicular pain 2 hours ago, and no history of trauma. So he's come into A&E with testicular pain. And what would you like to know first? So obviously you want to take a history and sort of your standard pain history, the site of which is in the lower abdomen and the testicle. He's complaining of severe acute pain. It's sharp shooting, and it's radiating to the abdomen, groin, and genitalia. You've got some associated symptoms, so he's complaining of nausea and vomiting, and got some testicular and groin pain, sort of genitourinary system. Timing-wise, it's a constant pain. It came on suddenly, as we said before. There's nothing that makes it worse or better. It's just very severe at 11 out of 10 severity. So you move on to your exam, and what you find is there's some suprapubic abdominal discomfort without any guarding or peritonism. And the right testicle is exquisitely tender without any erythema or redness, and it is a horizontal lie. So that's an important thing to note. And also, there's no pain relief on elevation of the scrotum, which is called a negative friend sign. There's also no cremasteric reflex on that right side, in the right testis. So there's a few things here that you should start to be thinking of what this could be. You do some investigations, so quickly you do a urine dip, not female, but with every patient with abdominal pain, if they're female, do a pregnancy test, ECG, and then your basic sort of bloods, and coag, GNS, and a lactate. And then in terms of imaging for this, you get an ultrasound Doppler study, and you see there's absent or decreased flow in the testis on the right side. So what are you thinking at the minute? There should really be one thing that's standing out to all of you, and that is testicular torsion. But there is a whole other host of causes of testicular pain, and many of you that have done general surgery jobs or urology jobs will definitely have found it's more rare to have actually found a torsion when you explore a testicle than not. So it's important to consider all the differentials. So you've got a testicular torsion, but it also could be a torted hydatid of Morgagni, which shows a blue spot at the bottom of the testicle. Now, this is really difficult to diagnose, and I wouldn't recommend, as a junior especially, trying to diagnose this, and an exploration is definitely always warranted in acute testicular pain if you're worried about torsion. There's also epidermolysis, infection, hydrocele, varicocele, testicular cancer is a really important one. Scrotal hematoma, especially in the context of trauma, in which this patient hasn't had any. And a very important one is Fournier's gangrene. So the very first sign of Fournier's gangrene could just be testicular pain, scrotal pain, and it's something that would develop obviously fairly rapidly in time. There's also a couple of other differentials to consider. So abdominally, you do get some referred pain to the abdomen, so you need to consider whether the pain is actually coming from the abdomen or the testis. So appendicitis could mimic this, renal colic could mimic this. And interestingly, with testicular pain, you often get referred pain to the L2 level, which is sort of the tummy, lower tummy region. And that's interesting because that's where the testicles descend from in the abdomen, the L2 level. So it makes sense that pain is referred there. When you have testicular pain, you'll have abdominal pain. So that's important to remember. And when doing a differential, it's always important to, when you don't want to miss anything, to use a sort of systematic approach. So I quite like the surgical sieve when considering differentials. So if you just remember vitamin C, D, E, F, you'll remember vascular, infective, trauma, autoimmune, metabolic, iatrogenic, neoplastic, congenital, degenerative, endocrine, and functional. And there, if you use that tool, you usually won't miss anything in terms of your differentials. So definitely use them. Some risk factors for torsion. So there was a few in this case, but essentially young male. So if you're young, you're at more risk of it. Neonates are at more risk of it. Having a bell clapper deformity, which is essentially where the testicle hangs more freely in the scrotum, giving it more space to twist on its axis, and that's because there's no attachment of the gubernaculum to the scrotal surface, giving it free rein to move and twist, essentially. Trauma or exercise, it can be something as innocuous as exercise that can tort a testicle, and having undescended testes. And this is that bell clapper deformity I was speaking about. So testicle isn't fixed in its correct axis, it's hanging loose and it's hanging horizontal. So this patient had a horizontal lie, probably due to a bell clapper deformity, which has caused a torsion. How do you manage it? So as with every acutely unwell patient, you use an A to E approach. You're not a monster, so you're going to give pain relief, and this is going to be a very painful thing, so definitely very important. And then you're going to be working them up for an exploration. So keeping them nil by mouth, getting anaesthetics to review the patient, book them onto CPOD for theatre, and this is really what you want to do. So an urgent scrotal exploration, plus minus orchidopexy, and just remembering time is testicle. So if you present within 4 to 8 hours and do the exploration within that time, the testicle, if torted, has a 90 to 100% chance of survival. That quickly drops to 50% at 12 hours, and then only 10% at 24 hours. So it really is something that you want to get right and get quickly sorted. And if a torted testicle is found, it's untwisted, put in warm saline swab for 10 minutes, and you examine to see if it reperfuses. So whether it'll be blackened or dusky, and if you untort it and examine for perfusion, it should sort of give some more colour back into it. If non-viable, you might need to take it out as well, and that can be a discussion with urology. And if it reperfuses, then fix both testicles in the anatomical position, because if one's been torted, you're at more risk of having another one. So that's why both are fixed. Just as a note as well, blood tests that I mentioned shouldn't delay emergency theatre if you do suspect torsion. So just to remember that. So just to summarise, we've covered the anatomy of the testis and the spermatic cord. We've covered how to do an urgent assessment of a patient with acute testicular pain, and especially in the case of torsion, the timer's testicle. So you need to be very efficient with your assessment. And an urgent scrotal exploration is essentially the main diagnostic investigation for torsion. You can't know fully if it's torted until you actually open the scrotum. So you can use Doppler. It is helpful sometimes in those cases where you're unsure, but really the gold standard is do an exploration. And also just remember there's a wide array of pathology for testicular pain. It's actually quite uncommon for it always to be torsion every time they're presenting to A&E. So definitely just consider a wide differential and read about that in your own time. Thank you.